Welcome to part two of our guest lecture today. And today we're going to be talking about the first of a couple of case studies that I want to share with you about the role of using qualitative methods. And in this particular example, we're going to talk about the role of faith in relation to cancer prevention in the Somali immigrant community. So just by way of background, women from East Africa have some of the highest rates of cervical cancer in the world. And we know that Somali patients in Minnesota have very low rates of cervical cancer screening. And that's not unique to just cervical cancer screening. We also see that we have low rates in mammography and colorectal cancer screening. We also know that we've got a large and vibrant community of Somali immigrants living in Minnesota. And despite lots of many wonderful strengths and assets in the community, many people have had very limited prior experience of preventive health care, particularly in relation to the experience they might have had in Somalia or other host countries that people spent time with and before settling in Minnesota. And there's a great need to try to address these disparities. I was involved in a study some years back where we did work to understand cancer screening utilisation by Somali men in Minnesota. And one of the conclusions of that study was that, and I've just pulled this one out here, most participants described a belief amongst Somali men that getting cancer is God's will and one has no control over God's will. And this is one of the findings that we wrote about in the paper. Now, when this work was being presented to an audience that included a clinician, after he heard these findings, his conclusion was this. So this makes me think I shouldn't even bother suggesting getting cancer screening when a Somali patient comes into my office. So there's a very good example of, through doing all of our best effort and our well-intended work, the way in which we had presented our findings had led someone to think that instead of taking the call to do more and to be active in trying to engage patients in cancer screening and thinking about all the things that are important in doing that, it made at least one provider feel that they should give up, which is exactly the opposite of the type of goal that we have as health disparities researchers. So what happened? What went wrong with that? And so if I return for a moment back to what I call my compass of these four aspects of data theory, context, and reflexivity. So in terms of the data, we identified focus groups with Somali men that was probably relevant and the right thing to do. We talked to men in groups. That's a frequently expressed preference in the community. In terms of theory, we had used a grounded theory approach to analyse the data, and that had guided us. But in terms of context and reflexivity, we probably made some missteps. So had we really thought through the broader context of how some of the barriers to preventive healthcare might be perceived by providers, and had we really thought through how to represent some of the other barriers that might be at play, or the way in which we described an aspect of Somali culture by saying that something was considered to be God's will. Had we understood that well enough? And probably we had not. In terms of reflexivity, how had we as a team spent time to think about how our identities were different than the identities of folks in the Somali community, and how did that impact our thinking, particularly as a research team that might have been less familiar with some of the Islamic principles of health? What attention had we given to thinking a little bit about the differences between us as a team and our knowledge and what we needed to know in order to do a really good job of answering this question? So we had another go. I, with others, developed a collaboration with faith leaders in the Somali community, in particular, working with a local imam who is the leader at the Dar al-Hijra Mosque in Cedar Riverside. It's Imam Sharif Muhammad. And working with him, we said, hey, tell us a little bit more about this idea about God's will and what does it mean? So we enacted a journey of exploration to try to understand more what are the kinds of culture and faith-based messages that we hear, and how can we understand those better? And that journey led us to understand that actually, while the literature, and including this one piece of literature we had just written, consistently positions faith as a barrier for Somali patients and often Muslim minority group patients to take part in cancer screening. When we engage more fully with a faith leader, there's actually a range of Islamic values that are connected to health and well-being that are very health promoting. And one of those values is about predestination, and this is what this concept of God's will is talking about. However, the Imam was able to clarify and kind of broaden the dialogue to say a belief in predestination does not prevent one from striving to ward off harm. So it doesn't necessarily mean you can't have cancer screening, or that if you have cancer screening, you've bypassed your predestiny. But cancer screening can promote a balanced and careful life that respects the will of Allah, because there's a will to look after your mind, body, and soul in harmony. And perhaps just as cancer might be part of your destiny, so may be the opportunity for screening and the opportunity for treatment. This value of mind, body, and soul in a holistic manner, again, is also very important, and that gives us an opportunity to start talking about the value of faith and how that might actually be really important for promoting holistic health and promoting doing things such as doing really active things to look after your body as well as your mind and your soul. A common barrier that we have heard from cancer screening providers is that there's lots of concerns about modesty. And again, the Imam was able to kind of broaden the message to say, really, there's a dialogue and a discussion about modesty, and that's not just about action, it's also about intention, and to provide some guidance about when it may or may not be the right kind of context to share very private parts of one's body with somebody else. And finally, an assertive message about the value of pre-screening for diseases and how that's consistent with this healthy, balanced lifestyle. And as such, it might be a really valuable thing to do. So we explored and we developed these faith-based messages to kind of broaden our understanding of the value of faith, the idea of fate or predestination, and some of the other issues that we'd heard about. What we did is we actually worked to test these messages with both Somali women and men around, how do these messages relate to you in relation to how you might be thinking about both breast and cervical cancer screening. Now, you might be wondering why we had involved men in that, and that was certainly something that we did at the suggestion of the community, who really pointed out that there's lots of times that men and women might be making decisions together and in intergenerational ways about cancer screening. And our finding from this second study was that faith can play an important role as an asset to promote breast and cervical cancer screening. And there may be substantial benefits to adding faith-based messaging to other interventions that focus on improving screening uptake. So that's a very different conclusion, and it shows the value of really pausing, collecting qualitative data from people around specific aspects of messages, providing more partnerships where we can get more an informed and useful narrative in terms of that we can develop these messages together, and then we can share them with the community for their feedback. So what happened next from that is that it led to the development of a new and effective community academic partnership. This process of qualitative research led to an increase of community engaged input, which not only improved the quality of the work, but also the relevance of the work to the community. And from those messages, we went on to develop a religiously tailored workshop that centres faith as an asset for improving cancer screening, and using those messages as a way to foster and develop dialogue within the community in groups that can broaden some of the discussion around cancer screening. The work has been tested with positive results to this date, and that the faith-based workshops that we've held were very well received, and we likely need to work to secure further funding to be able to test it more broadly as well, in terms of having the resources to be able to see, what is the really long-term impact that developing this different kind of approach can have on actual screening uptake. And with that, I'll pause, and that is the first case example that I wanted to share with you. I'll pause the video there and then upload a second case example I'd like to share with you shortly, along with some concluding comments.